My aim for today is to talk to you about the radiological principles associated with bronchiectasis. The objectives are to tell you the definition of bronchiectasis on imaging and how to recognize bronchiectasis on imaging. I will also speak to you about the different types of bronchiectasis that one may come across on imaging and also the differential diagnosis of bronchiectasis that one has to consider whenever you're dealing with a patient. So next time you see a CT and you see bronchiectasis, you can go through a checklist to try and arrive at the clinical diagnosis of the patient. Airways can be broadly classified into proximal, middle, and distal. The proximal airways, where we are talking in terms of trachea, the pathology tends to be either an endobronchial obstructive lesion, or you could have a cancerous growth which is causing compression from the wall inwards. The middle airways are the bronchi, which involve the lobar and segmental level, and this is where you tend to see bronchiectasis. The small airways tend to have more of a pulmonary parenchymal involvement rather than obvious bronchial pathology. So we're going to be seeing more to do with this middle and the smaller airways in this presentation. Bronchiectasis by definition is irreversible dilatation of bronchi. And on imaging, when you look at the CT scan, each bronchi is accompanied by a vessel adjoining to it. The vessel and the bronchi are meant to be of the same size. When the bronchi starts to dilate more than 1.5 times of the adjoining vessel, then that is one of the signs of bronchiectasis. This appearance is called as a signet ring appearance, like a ring with a small diamond on top of it, which is very classical for bronchiectasis. The other definition of bronchiectasis on imaging is non-tapering of bronchi. As we go from the center to the periphery of the lung, the bronchi tend to taper down and become smaller and smaller. But in bronchiectasis, these do not taper and these remain open or of the same size. This is the second parameter of bronchiectasis on CT. The third parameter of bronchiectasis on CT is the visualization of bronchi towards the periphery of the lungs. When you look at a normal lung, at the periphery or the subpleural aspect of the lung, there are no obvious bronchi visible. When you start to see these bronchi going all the way out to the periphery, it is suggestive of underlying bronchiectasis. So, 3 parameters: dilatation of bronchi, non-tapering of bronchi, and visibility of bronchi towards the periphery of the lungs make bronchiectasis diagnosis on a CT scan. There are other features which are visible on a chest radiograph called as a tram track sign, or there are features of air trapping and nodular changes which we will be dealing with later. Please do note, I am only talking on CT in today's talk because X-rays are extremely useful in diagnosing it but are not very useful in differential diagnosis of patients. You may see bronchiectasis on a chest X-ray, but there are many cases where bronchiectasis is underdiagnosed on a chest X-ray, and CT perhaps is much superior in getting to the bottom of these cases. This is another example of bronchiectasis where you can see non-tapering of the bronchi as we go to the periphery, and another example of what is called as a signet ring appearance. The dilated bronchi, the black hole here, and then the adjoining artery or the vessel which is next to the bronchi. You can see the bronchi all the way out to the periphery, suggestive of underlying bronchiectasis. When we talk about types of bronchiectasis, there are 3 types of bronchiectasis that we deal with. The most common type is the cylindrical bronchiectasis, where we see elongation of the bronchi along the path, and it is very simple and the most common type of bronchiectasis. The second type of bronchiectasis is called as varicose bronchiectasis. Varicose bronchiectasis is basically irregular dilatation of the bronchi. Some areas are very much like cylindrical, while some areas are tortuous. These tend to be associated with areas of fibrosis or areas of post-infective change. The next common variety of bronchiectasis we see is cystic bronchiectasis. Cystic bronchiectasis is nothing but cystic replacement of the bronchi in the lung parenchyma. They often tend to be in clusters, and you can see them together, as in this case, in different lobes of the lung. There are two myths that we all need to be very clear about. Bronchial dilatation does not mean bronchiectasis, and also traction bronchiectasis is different from bronchiectasis. Now let me show you one example. This is a case where you look at this and you say this is bronchiectasis. You can clearly see that the bronchi are dilated, and this is the patient after therapy or after treatment. And you can see the bronchi have all become normal. So bronchiectasis by definition is irreversible dilatation of bronchi and not just dilatation of bronchi. In patients who have got infection, there is usually some degree of bronchial dilatation, as is seen here. And once the infection is treated, you can see that the bronchial dilatation gets better. The second part is traction bronchiectasis versus bronchiectasis. Bronchiectasis is purely an airway pathology, and it has nothing to do with the adjoining lung parenchyma. In traction bronchiectasis, the primary pathology is in the lung parenchyma or the interstitium around the bronchi, which is leading to pulling of the bronchi apart or traction of the bronchi, which is why it is called as traction bronchiectasis and is seen in interstitial lung disease, especially the fibrotic variety. Once you have seen bronchial dilatation or other features of bronchiectasis, you should start looking for secondary features. One of the most common secondary features that you will see is wall thickening. The bronchi gets thicker and thicker secondary to underlying infection and inflammation, and you start to see these bronchi get filled with either mucoid material or fluid. So bronchial wall thickening and dilatation is one of the common secondary features of bronchiectasis. Also, look out for nodules. You can see nodules which are suggestive of a smaller airway involvement, and you may have to zoom in sometimes to be able to see these nodules. These nodules tend to be peribronchial in distribution, and some of them can have a tree in bud pattern, which is seen in endobronchial spread of any infection. So bronchiectasis can be associated with nodules. Invariably, when you're seeing these nodules, it means that there is ongoing active infection. The third feature commonly seen with bronchiectasis is air trapping. Now, if you see in this lung, you can see this is kind of the normal density of the lung here. This patient has got these large cystic bronchiectatic changes, and you can see the lung here is much darker. The same can be seen across here. Adjoining area of bronchiectasis, the lung is much darker compared to the other parts of the lung, which are normal and much brighter. So air trapping is another secondary feature of bronchiectasis. The next important point of today's talk is finding out a cause of bronchiectasis. Now, just purely based on imaging appearances, you can try and decipher a cause of bronchiectasis based on the location of disease. And it is shown that if we do that, we will be as accurate as about 50 to 55% of times. If you add the clinical history and the HRCT distribution pattern, the accuracy of the diagnosis increases more than 90%. So you are going to be in a very good position with the clinical history and the knowledge you gain from this talk to be able to differentiate different causes of bronchiectasis henceforth. Let's look at the distribution-based differential diagnosis. Now, if we see this as a lung of a normal patient, there are specific pathologies which cause bronchiectasis in the upper zones, especially TB and sarcoid, which we all are very commonly associated with and treat it in our day-to-day practice. The other common thing that you may find in the upper lobes is cystic fibrosis. It can also be diffuse in nature, but classically it starts in the upper lobe. The next major chunk of pathologies involve the mid-zone of the lungs. These are typically seen in atypical mycobacterial infections such as Mycobacterium avium intracellulare and ABPA. The fungal infections tend to be perihilar or around the bronchocentric region in the mid-zone of the lungs. You can also see bronchiectasis secondary to ARDS related changes in the midzones. Lower lobe involvement is much common and is usually seen in patients with recurrent aspirations or people who have recurrent infection. We will be discussing about this a bit later in today's talk. Also, you can see this in patients with interstitial lung disease who have fibrosis, where the disease involves the lower aspect of the lungs. The other important feature which helps us in differentiating between pathologies is the unilateral nature of involvement or one lobe involvement of the bronchiectasis. This is usually secondary to either underlying infection at a current time or as a childhood disease seen in Swyer-James syndrome, or secondary to bronchial atresia. Now let us look at a combination of the clinical suspicion along with distribution of bronchiectasis and try to look at some of the cases of real-life bronchiectasis. If you are thinking of infection or aspiration-related pathologies, you are often looking at a lower lobe or lower lung zone distribution with aspiration. The ABPA, the allergic bronchopulmonary aspergilloma, tends to be more upper lung zone and can have a perihilar distribution. Then you're looking at the infection of atypical mycobacterial, which is again in the mid zones. And if you're looking at Swyer-James, it tends to be unilateral or focal. This is one example of a recurrent aspiration where you can see the pathology is predominantly in the lower lobes and along the posterior basal segment of the lower lobes in a patient who's got recurrent aspirations. ABPA classically involves bronchiectatic segments in the perihilar distribution in the upper and mid zones. One thing, if you see, are these hyperdense areas of mucus plugging. So these are bronchi which are filled with hyperdense material. This is highly suggestive of a fungal infection. There is a pattern which is called as a finger in glove appearance, whereby all the bronchi are actually filled with mucoid material and fungal material, and this is quite characteristic on a CT scan. However, you may see atypical presentation also, whereby all you're seeing are central bronchiectatic changes in a perihilar distribution with some areas of endobronchial mucus plugging. So if it is perihilar central areas with mucus plugging, especially in an asthmatic, then think in terms of ABPA. The mid-zone involvement is fairly typical in terms of a atypical mycobacterial infection, often happens in older women, and it is in the mid-lobe and the lingula where you start seeing these bronchiectatic changes. You may also see areas of middle lobe collapse itself or significant loss of volume in these patients. There is often a tree in bud pattern associated with this abnormality. TB, we are all very comfortable. We have seen loads of TB in our clinical practice, whereby you're seeing unilateral or even bilateral apical involvement of bronchiectasis with associated loss of volume and some pleural thickening. You can see similar changes in the superior segment of the lower lobes also. In Swyer-James syndrome, you're looking at large areas of hyperinflation, often unilateral in nature because of childhood infection involving one side. You can see this is a patient, and this is the right middle lobe, which is significantly hyperinflated, and you can see it's pushing the mediastinal structures to the left side. You can also see unilateral or focal areas of bronchiectasis in patients who may have infection, and that can lead as a fibrotic area, and the one lung may be normal while another lung may have these bronchiectatic changes. The next group of etiologies are those of congenital nature. So you can have cystic fibrosis where there is upper lung zone involvement which goes on to involve diffuse areas. These patients often have recurrent infections as childhood. You can see Mounier-Kuhn syndrome whereby the larger airways such as the trachea are dilated and you get a tracheobronchiomegaly in these patients, essentially central in nature, starts at the level of the trachea itself. You can also see bronchial atresia with total absence of bronchi. Cystic fibrosis is a pattern which is classically described in upper lobes but is more often diffuse in nature, and you can see areas of cystic change. Also, you will see areas of fibrosis, and a lot of these patients will have bronchial wall thickening with endobronchial mucus plugging. Another congenital anomaly that one has to look for is keratogenous syndrome, whereby you look at the heart, there is dextrocardia, heart pointing towards the right side, and you see there is bronchiectatic changes in the lower lobes. This is fairly classical and usually does not cause much of a diagnostic dilemma. CVID or common immunodeficiency syndromes are cases where you get recurrent infections with different morphological pattern where you often are seeing lower lobe predominant bronchiectasis. You will see areas of endobronchial mucus plugging with multifocal areas of air fluid levels within this. The final group that we look at in bronchiectasis in terms of etiology are those of fibrosing or diffuse lung disease, sarcoid being the most common one, where you can see upper lobe involvement of bronchiectasis. You will see loss of volume and some calcified lymph nodes. Pulmonary fibrosis as part of interstitial lung disease will also give you bronchiectasis, but that would be of a traction bronchiectasis nature rather than a simple bronchiectasis. The last group we look at are post-recovery from ARDS can also lead to bronchiectasis. These are two examples of patients with fibrosing interstitial lung disease whereby you're seeing these non-tapering dilated bronchi going all the way out to the periphery in a patient who's got extensive honeycombing with UIP pattern of IPF, while this is another patient where you're seeing diffuse ground glass consolidation in the lower lobes with traction dilatation of bronchi in a patient who had CTD associated NSIP or non-specific interstitial pneumonia. So as a refresher, if you're dealing with lower lobe bronchiectasis, first and foremost look for situs. If there is dextrocardia, it is keratogenous. The next parameter to look for is trachea and see if there is tracheal involvement, which is seen in Mounier-Kuhn syndrome. The third thing to look at would be to understand the immune status of the patient. If the immune status is low, then you're dealing with CVID, HIV-associated immunodeficiency, or even IgA deficiency. You may also be dealing with alpha-1 antitrypsin deficiency, whereby you will see bilateral lower lobe bronchiectatic changes in patients. Also, you want to look for symptoms suggestive of aspiration and history of aspiration, which will help you to say the cause of lower lobe bronchiectasis as aspiration. You also look for connective tissue diseases to make sure that there is no associated interstitial lung disease. So this is the differential diagnosis that you have to deal with whenever you're looking at lower lobe bronchiectasis. Once you do not find any of the cause, then you may entertain the diagnosis of an idiopathic bronchiectasis. But more often than not, we do find a cause of bronchiectasis. I would like to introduce two concepts to you which are slightly away from bronchiectasis but are useful in these patients. One is bronchiolitis obliterans. Bronchiolitis obliterans is nothing but bronchial dilatation with large diffuse areas of air trapping. This is one of the features which is commonly seen in drug-induced ILDs or any drug reaction. or is seen in patients who have transplant rejection, be it lung transplant, be it heart transplant. It is a form of graft versus host disease. Patients who have got bronchiectasis often present with hemoptysis. It may be disregarded as just bronchiectasis, but you definitely do not want to miss out any focal aneurysms, any focal bleeding points in these patients. So it is important to assess the pulmonary arterial system as well as the aortic system to see these bronchial artery collaterals, which can then be embolized in appropriate patients. I would like to acknowledge these three resources which I have used in preparing this presentation. And in summary, I would like to tell you that bronchiectasis is irreversible dilatation of bronchi, and on CT, it can be recognized by looking at non-tapering of bronchi, a dilatation of bronchi which is more than the adjoining vessel, and seeing bronchi in the peripheral aspect of the lungs on CT. It is different from traction bronchiectasis, which is seen in interstitial lung disease. Once you've seen bronchiectasis, it is important to look at the distribution of the disease to understand the etiology. Mid zones, you're looking at atypical mycobacterial infections. Upper zones, you're looking at sarcoid, TB, cystic fibrosis, while lower zones, you're looking at recurrent infections, aspiration, CVID as part of your differential diagnosis workup. It is important to know the history and combine it with the distribution, and you will be able to get to the bottom of diagnosis most of the times. Finally, patients who present with hemoptysis, you need to make sure that there are no bronchial artery collaterals or aneurysms in the areas of bronchiectasis accounting for hemoptysis. Thank you very much for patient listening.